And to end off this morning session with questions for the day, I'll welcome Tom Gardner. Tom is a professor of ophthalmology here at the University of Michigan. He's the co-director of the JDRF Center of Excellence here. And Tom has played a pivotal role in this initiative as the co-scientific director. Thanks, Tom.
Well, good morning. Thanks very much. It's great to see you all. And this initiative, as Robert said, relies on everybody's participation. So there are really two broad questions here. The first and most obvious one is to test the hypothesis that incorporation of patient symptoms or other measures of their function can improve the diagnosis and treatment of diabetic retinal disease. I state that as emphatically as a hypothesis, so because we don't know that, and we're going to test that in a rigorous fashion. So it's interesting because every medical student learns that in evaluating patients, it's the symptoms, the physical signs, and the tests. It's the structure and the function put together in any routine clinical assessment. Certainly, it is very important in every aspect of clinical medicine. And in other diseases, particularly other complications of diabetes, such as cardiovascular disease or renal insufficiency, it is a combination of structure and function that is put together to help guide the patients and to be able to treat the patients before they get end-stage disease. Assessment of function has always been an integral part of the assessment of glaucoma or patients with glaucoma. It has always been an essential part of the assessments of patients with inherited retinal diseases. Diabetes doesn't have that. It's the outlier. And it's mostly for historical convention that we're here. So can we learn from these other fields and help in doing so, help the patients? The second question then might be framed as, can we or will we actually commit to working together to solve this problem? It's easy to sit here and think about that and say yes this morning, but this is at least a 5 to 10 year commitment, maybe longer. So that means a lot of our lives, it means a lot of money, and it means a lot of collaboration. And so why should we really do this? Well, as Ryan told us, he did everything he was supposed to do as a patient, and that he still has suffered very severely. He still had to have surgery and destructive laser. And so we're treating retinopathy at end stage. It's equivalent to doing dialysis for kidney disease. So are we going to do this? Well, if our emphasis in our center is, as Sanjoy said, on the patient. So for Ryan, Catherine, Michelle, Sydney, and Houston, we must. Thank you.